So, pediatric optometry, I suppose the question I want to ask is, why are you doing this particular course? I'd like to know, because I'd like to ask this question firstly. How many of you see 1 to 2 year olds? 1, 2, 3. But some people are putting their hands up. Yeah, but you see 1 to 2 year olds. So some of you I've seen, I presume, with ophthalmologists, yes? Or by yourself?
Sometimes by myself.
Very good. That's what I like to hear. The revolutionaries. Yeah, very good. And of course, you know,
just work with
an ophthalmologist. Yeah, okay. How many of you who don't work with an ophthalmologist are seeing under 5 year olds? 2, 3. So, are you doing this? I think I understand the law is that you shouldn't be doing this. Is this right?
It's not exact because there are
We are not allowed to
regulations. There are regulations that are supposed to be set in the law.
Yep.
But no Ministry of Health have ever set the regulations. So there is no definite age for a child, and it's very grey.
Very good. So you can create precedent. There's still room for precedent. Yeah. Okay. So how about 5 to 10 year olds? So more of you doing 5 to 10 year olds. Okay. And greater than 10, I guess everybody. Yes. Okay. All right. So I think that for younger children, 1 year olds, there's 2 questions really that we're trying to deal with. Firstly, are the eyes healthy? And secondly, is there amblyopia risk? Those are the 2 things, the 2 main aims for when we're looking at little children. Okay, so let's just go through a few. I suppose these are tips and discussion points. Should you treat children like little adults? You say no. You say no. Okay. So when they're very small, you can't treat them like adults, but nevertheless you should treat them with respect. So as soon, in my experience, in my opinion, as soon as they can understand you, you should be talking to them. So for example, before you put drops in, it's very much better, I think, to explain somehow that you're going to do this. So in that regard, you're still treating them like people. They're not. You don't ignore their feelings. So those of you who are going to specialise in children, you might want to think about having special equipment. Certainly in your office, I guess, there's a little table, little chairs, that sort of thing, with things to draw. Sometimes in a regular optometry practice, there isn't space for all this, but you need to try and have something that will make them feel at home. And the toilet, of course. The parents need to know where the toilet is. It's probably the most important room in your practice when it comes to children. Okay. Who wears a white coat when they see children? Okay. It frightens them. Okay. So, in my opinion, it's good to go out to meet the child. You come out and you greet them, and you get down to the child's level. So you come down and you come down to eye level. Otherwise you look like a giant to them, and they're often a little nervous. So when a child comes into a consulting room for the first time, it can look very frightening to them. They haven't seen it before. So you want to try and make them feel at home. So come and sit up on your magic chair, your throne, all this talk. Try and make a verbal connection if you can. For those who are speaking, you want to start and try to get them to speak to you. You know, some little children, they don't say anything at all. They're quiet, and you want them to respond to you. You want them to tell you what they're seeing when you're doing visual acuity. So you need to try and get them to talk. And of course, sometimes, once they start, you can't stop them. So it's children vary, of course. Observe the child. As they come into the consulting room, look at what they're doing. Look for motor organisational difficulties. Does the child sit still? or is he or she hyperactive? Very often when I'm writing notes on my computer, I can hear them touching things and their legs are going up and down. These children who don't sit still, as you know, those of you who do, if you look at children who have learning underachievement, they're hypermobile, they're fidgety, and you can tell by their general behaviour this is the case. Who should be with the child? Well, I have a low attention span myself. So I like the mother to be there or the father to be there. I do not like brothers and sisters in there. Now, one of my clinical partners in my practice, Menachem Silasnik, who actually will be giving you a lecture. He lives in Israel. I've mentioned him before, and he commutes. He comes back to London every second week. Somehow he doesn't mind having 6 brothers and sisters in the consulting room with him. I can't concentrate, so I try and keep just the mother or the father. Okay. Listen carefully to the mother. Listen carefully of any observations reported by the grandmother. If the grandmother believes that there's a squint, a strabismus, psila, then there probably is one. I mean, you've got to rule that one out. And sometimes you have a tentative diagnosis in your mind even before you've started examining the child. So if somebody comes in, the mother comes in with a 5-year-old or a 6-year-old and says he keeps blinking all the time, what's on the top of your mind?
Two things, or dryness or blurriness.
Dry eyes or
Blurriness.
blurriness? Any other offers?
Pressure.
Pressure, okay. Any other offers? Okay, we'll come. I'm sorry.
Double vision?
Double vision, okay, could be. All these are, but probably I have a more favourite one that we'll come to. Dry eyes is up there actually, but there's another one which is more common. Obtaining history and symptoms. How long can this child sit still while you're talking to the mother? Now, usually with an adult, of course, you'll take symptoms and history at the beginning. Sometimes, if you can see this child will not sit still, you might need to move on to other things and come back later to ask questions. Ask the parents the questions. Now, you know that you get the mother who says, well, my 3-year-old can answer the questions himself. Okay, so you know this. So you ask him, and he doesn't say anything. So you ask the parent, of course, but do ask the child, particularly when there's learning difficulties. There are certain questions you want to ask that 7-year-old. When you're looking at print on the page, does it stay still? Is it clear at all times? And so on. Okay, work efficiently. You may need, as I've just said, to tidy up some of your symptoms and history at the end of the examination. Keep talking. With younger children, you need to keep their attention. So this is why it's very difficult for students, undergraduate students, to see children, because they're not fluent with their regular examination techniques. So you're all very experienced, so you can do 2 things at once. So, given a positive history, most children probably are abnormal. You think abnormal. If a mother says, I think there's an eye turning, you're going to assume there's a strabismus, or that you're going to assume there's a symptom until you've proved otherwise. So this is then not screening, this is case finding. You're going to work up and find out what's happening. Otherwise, if there's no symptoms, then you're screening. So a child comes in, why are you coming? What's the reason for you to come today? I just want a routine check, I don't see any problems. Probably normal. So here you're doing a screening. Okay. So why the visit? Symptoms and history are very, very important indeed. Is it a routine check? And I just want to say again, because I've said this before in previous lectures, symptoms and history, very important to write everything down. I'm going to discuss with you during the course some case histories. And 2 of them are medico-legal cases that I've just finished in the UK on children, with optometrists who've had a problem with children. And very often the issue is poor history taking, poor symptoms, and you come to look at the records and there's nothing there, or very little there. So is there a family history of visual problems? Did they fail a vision screening in school? In the UK, they have a school vision check at the age of 4 or 5, and then they start coming in. Now, of course, they should have a check. Every baby should be checked at 1, but there aren't enough optometrists or ophthalmologists to do that, and there's particularly not enough practitioners in Israel. Israel is a very strange case because you've got a few ophthalmologists, very few pediatric ophthalmologists, and you've got very few official primary care eye care practitioners, because optometrists are in this difficult position of no eye drops, this sort of thing. Whereas in the UK, we have 13,000 optometrists, lots of primary care practitioners who are able to do this. But I must tell you though, many optometrists in the UK are not comfortable seeing 1-year-olds or 2-year-olds. 3-year-olds, they start, but babies, not so many are that comfortable. Has the child been referred by the GP, by the paediatrician, ophthalmologist or teacher? Some of you will receive referrals from teachers because there's a learning underachievement. Maybe the parents notice the sign, or perhaps the child is reporting symptoms. In my practice, I get a lot of what I call visual assessments. These are children who are underachieving at school, and we want to rule out a visual correlate of the dyslexia, the correlate of the dyslexia, not the cause, the correlate, or is there some cause of the non-dyslexic underachievement? And sometimes they just want a second opinion. They've been somewhere else, they've been told the child needs glasses, and the mother or the father is not happy with the idea of wearing glasses, so they come for a second opinion. By the way, it's always very easy, or it's easier for the second practitioner to find a problem or to sort out the issue. Please always be careful about criticising another colleague. If it's an optometrist or an ophthalmologist, avoid being critical. Always say, in my opinion, he does need glasses, or he doesn't need glasses, or in my opinion, he needs this treatment or that treatment. Don't say, this is wrong, or that's wrong, or why has he got glasses? You know, this gets other practitioners into trouble. Many medico-legal cases in the UK come because some young ophthalmologist in the hospital has said, oh, this glaucoma has been here, or this strabismus has been here for many years. Why wasn't it picked up before? And that kicks off a case. That's not very good either. It's negative. So history, birth history. It is important to ask some questions and record it. So you can ask, was there a normal birth? And usually the mother will say yes, or no, they were born at 32 weeks. So record this. Forceps, was there a forceps delivery? The mother will normally tell you, 40 weeks by forceps, or 32 weeks. Then you can ask, did the baby need help? Did they need to have oxygen? Also, was there rubella in a child? And some of these, in the mother, some of these questions you might go back and ask afterwards. A quick question on developmental history. Were the milestones normal? Did the child crawl, walk and talk at normal ages? It doesn't take long to do, and it doesn't take long to record. Are there any motor organisational difficulties? Is the child clumsy? Do they knock things over? Do they have speech problems? This is particularly important when there's a child who is underachieving at school. General health. Is he in good health? I normally just say, is he in good health? Has he had any past serious illnesses? No, everything's fine. Again, for children who've come because of a learning problem, ask, was there any ear, nose or throat history as a baby? Did they have glue ear? I don't know what that is, but if it's otitis media. Fluid in the ear. Are there any allergies? Educational progress, reading, handwriting, spelling, sports. These are questions you can ask as well. I don't personally always ask all of these. One way of doing it is to give a questionnaire to the parent before they come, but that isn't always filled in. But it's important to get general history. Are they taking any medicines? Were they born normally? Are there normal milestones? And some additional questions if you want. Family history. You want to know, is there strabismus in the family? Myopia, high astigmatism, eye disease. Anything in the family? Symptoms. Well, in infants, in babies, symptoms are not symptoms usually, because babies don't complain. It's usually here we're talking about signs. Sign, of course, is something that's noticed, symptom is complained about. For children then up to the age of 5, it's usually signs that are reported rather than the child saying, I've got something wrong. Sometimes they do say, I've got a pain in my eye, but not often. Remember, parents see their child all the time, and so the grandparents. So you're looking at the child just for half an hour, they see them all the time, so that the information is very important. But occasionally a child will report symptoms. It's very important, not just for children of course, but for all patients to ask, how long have these symptoms or signs been present? And it's very important to get into a routine. If there are 4 symptoms, for each symptom ask, how long has that been there? How long has it been there for? You need to get into this discipline of recording this. So what is more important? A nicer chorea, a different sizing pupil that was noticed at birth, or one that came suddenly at the age of 3? Well, obviously, the one that comes suddenly is important because that might mean a neurological problem that's just come. So these are some signs that I find occur most commonly in optometry practice. So occasionally they'll come in with a red spot in the eye, but remember of course that babies are often born with a subconjunctival hemorrhage. They've been pushed through the birth canal, there's the valsalva, and they've blown the blood vessel. But it can be caused by abuse. It can be the child's been hit. So, and we come on to a lecture on child abuse and eye signs later on in the course. A squint, or an eye turn, bacilla, strabismus. Could it be a real strabismus or a pseudo-strabismus, like epicanthus? Epicanthus is very common. Watering eye. Now, watering eye is very important. Up to the age of 11 months, babies very often have a watering eye. And we don't normally do anything about that, apart from massage. After 11 months, the child may have an operation on the canaliculus, but up to 11 months, it tends to be a developmental problem. However, there can be ectropion that's causing the watering eye, and very importantly, ophthalmos. Now, you won't see infantile glaucoma very often in your practice. You'll see it in your pediatric practice, possibly with the ophthalmologist, you might see it. But just do remember, if a mother brings a baby in to see you and the baby's eye is watering and they're photophobic, think, could it be glaucoma in this baby? There can also be conjunctival and corneal anomalies. Now, sometimes they come in and they say one eye is bigger than the other. This could be proptosis, ptosis, ophthalmos, Duane syndrome. Do you all know Duane? Yeah. Lid retraction, anisocoria. Often a different size pupil is mistaken for a different size eye, or they call it a different size eye. They keep rubbing their eyes. That could be due to conjunctivitis, binocular discomfort, entropion, or ophthalmos. Uncomfortable in bright light. Fair skin, blonde, albinism. Now remember, an albino can be just an ocular albino. The eyes are light, but the skin looks relatively normal. Or they can be oculocutaneous, where they're obviously albino with blonde hair, white hair, and no pigment anywhere. Okay. So symptoms in toddlers. Toddler is an English word for sort of one. Huh? Paotot, okay, toda. And older children. By the age of 5 or 6, children start to observe and report symptoms reliably. And these are some signs as well here. Sitting close to the television. Now, some children, you know, they just like to sit close to the television. Okay, but it can be ametropia as well, or reduced vision. But it can be this behavioural. Not good with colours. Well, obviously the first thing to check is colour vision. It doesn't always mean they've got a colour vision defect. You'll all use Ishihara, I guess, yes? Okay. Who checks Ishihara the first time they see a child? Always first time? It's good. Good to have it in the record. Yeah. Okay. Screws eyes up, photophobia, refractive error, of course. Blinking a lot. Now, we come back to this one here. Most, in my experience, probably more than 90% are behavioural. When they're blinking a lot, it's like a tick. Very often it's behavioural, and we'll come on to that. It can be psychosomatic. But it can be dry eye, it can be allergy, or it can be a conjunctival or corneal problem. Okay? So you need to use fluorescein on the child and check for that too. This was a study actually by a student who looked at symptoms of children presenting. So it was 1,000 children from birth to 16, and headaches was very common. Blurred vision, you'd expect it to be very common. And then you've got all these other ones. You've got blinking a lot, eye ache, suspected strabismus, double vision, watering eyes, screwing up eyes, photophobia, eye pain, and red eye. So most patients present to an optometrist either complaining of headaches or blurred vision.
They took all the vitamin K.
Retrospectively, yeah. It was a retrospective 1,000 patients going backwards, just looking at what the presenting symptoms were. It was a fairly simple study, yeah. Headache. If there is ametropia or an oculomotor balance problem, the child may stop doing what they're doing. They lose their concentration rather than continue and force themselves to get a headache. An adult has a deadline to finish their project, they'll carry on. But headache is not that common. So ask, where in the head is it? For how long and its frequency? Association. When does it come? Is it after reading? Is it after TV? Does it occur at school? And of course, if you get headaches only at school and not on the weekends, it might be from the eyes, but it might be from something else. They might not like school, yeah? There's a few smiles there. Okay. Do they wake up with it? Now, if a child, this is a very important question, if a child wakes up with a headache, what does that tell you? It's not eyes, it's not vision, almost certainly. There is, I think, in the literature, something about esophoria, poorly compensated esophoria, can leave a headache until the next day, I've read in the past. But generally speaking, if somebody, doesn't have to be a child, someone wakes up with a headache in the morning, it's not eyes. How long do they last for, and what makes them go away? Do they have to take? Does the mother have to give paracetamol? Obviously, if you can't find a cause for the headache, then refer the patient to the GP. Now, by the way, in the UK, if somebody has a headache, if it's a child and there's a headache, that is an indication to do a visual field test. I would say that if there's a headache on say, a 10-year-old or 12-year-old, and it's not investigated with a visual field, and God forbid there's something else wrong subsequently, and a visual field wasn't done, and there was a tumour or something where there was a visual field defect, there's trouble ahead. Okay. Now I know very few of you have visual field instruments. Blurred vision. Very often, as you know, children are not aware. They don't know that their vision is blurred. And it may just come up at school or at a medical examination. And very often, children don't realise one eye is blurred. They just don't know until they do this. And sometimes, I had one last week. I can't remember which child it was and the details, but one eye was quite poor. And in the consulting room, the child said, "Well, it's always been like this, Mummy." And the mother was shocked, you know. And then you can make the mother feel really guilty, you know. You didn't bring him earlier. Okay. Of course, sitting close to the TV or making mistakes copying from the board. Closing or covering one eye. That tells you, doesn't it, that there's probably, or there may be a binocular vision anomaly. If there's a recent onset strabismus, that will give diplopia. But an old strabismus, of course, a child that's 3, that's had a strabismus from the age of 2, there's going to be no diplopia now, and they won't have so many problems. You can ask the question, does he or she write lying down on the desk covering one eye? You all remember in your class there'd be someone doing that. This last one here is very interesting. Covering one eye in sunlight. It's pathognomonic of an exotropia. If a child goes out into the sun and closes one eye, there's an exophoria there that's breaking down, or an exotropia. It's almost diagnostic. You knew this one? Yeah. If it's double vision, you've got to work out whether it's one eye, or is it binocular? The monocular diplopia, or is it binocular? Vertical, horizontal, or oblique. Very often, an intelligent child will notice physiological diplopia for the first time and say to the mummy, "I can see 2 of you, mother," you know, and of course that freaks them out and they're in to come and see you. Well, of course they can see 2. If they're looking here, they see 2 in the distance. Okay. Monocular diplopia. Now, sometimes you get this, it can be pathological, rarely in a child. What's going to cause monocular diplopia in a child? Huh? Cataract will. But very often, it can be psychosomatic as well. But of course, you need to rule out everything first before you say something is psychosomatic. Frequent blinking. In my experience, most frequent blinking is psychosomatic or behavioural. It can be they're wanting attention, they're copying someone from school, or it can be psychosomatic where there's an underlying problem, and sometimes there's something called secondary gain, and we'll talk about this because there's going to be a talk on psychosomatic vision problems in children. Micropsia and macropsia. Intelligent children see things different sizes. You know very well if you accommodate hard on something close to, everything gets smaller. You see it gets smaller. This is micropsia. And an intelligent child will see this. Pain. It's rare in children. And I think if there's pain, if a child has pain here, they're probably going to go to the eye hospital or to their doctor. Perhaps rather than to the optometrist, but we get them coming in. My practice is we're like a little casualty station because I'm an independent prescriber, which means I can prescribe any drug, I can treat anything technically, and so they come in sometimes with foreign bodies or some other issues that need to be managed. If you can't find something wrong and they've got pain, refer. Don't hang on to the child, refer. Again, in the UK, it's become very difficult now because optometrists are now, they've referred the patient and they're being sued because they didn't make the right referral. you referred routinely, and it should have been an emergency. You know, it's becoming very, very, very much more difficult. Asthenopia, tired eyes, uncomfortable eyes. This, of course, is relieved by correcting hypermetropia or oculomotor anomaly. Remember, though, that a child may just lose concentration before getting symptoms. Photophobia, all these conditions can cause photophobia, sensitivity. So think about that. Advice to parents and the child. Remember, you can't always win. There can be crying either way, in the sense that the child needs glasses, and the child is crying because the child doesn't want to wear glasses. And then you get the child who does want glasses, and they're crying because they don't need glasses. And the most irritating thing, but by the way, you must appear to be sure. Once you've made the decision, certainly discuss things, but then be certain about it. Don't show that you're not sure, because that can cause problems. One of the most difficult things, and I actually can be quite, I can tell parents off for this. I have told parents off before. You have a child that needs glasses, and you look at the mother, and the mother's sort of like in shock. Oh no, he has to wear glasses. And I sort of say quietly, I turn around and say quietly to the mother something like, well, we need to be careful what we say, because it's going to affect, you know, and very often that does it. But some parents, of course, just don't want their beautiful child to be wearing glasses. Okay, motility. Be adaptable. You can use on babies, you can use your face. The face is the strongest stimulus. You're going to use a lighter toy, a hand. Now hold the head if need be. Okay, so use the face. You can pick up the baby. If it's a 6-month-old baby, you can't say to the baby, look at my light and follow my light. You know, they might do, but then they might do it in one direction, maybe in the other direction, then they've lost interest. So what you can do is ask the mother, can I pick him up? Can I pick her up? And you pick the baby up and rotate the baby. They will look at your face horizontally, okay, and then vertically. Tilt them that way, and you'll see a little frown come on their head as they look here, wrinkles. But I don't usually do obliques, because that's getting a bit cruel. Shaken baby syndrome. Yeah. Okay. Yeah. So there we are. That's looking at a baby. You can see the baby looking here. Visual fields. Now, can you do visual fields on children? Yes, you can. You can carry out static quantitative visual field tests on 5-year-olds, intelligent 5-year-old. A supra-threshold screening test you can do. Much more difficult to do a 24/2 full threshold, but you can do a C40. Okay. And there's other ways though. There's this test that actually I found it originally in a book by Kesten. Well, it was a paper by Kestenbaum in 1925, and it's in a book on eye signs of brain tumours. And this test Kestenbaum described was for adults, but it's very easily adapted for children. And kinetic outline perimetry is. I've brought my little stick with me. It's like a confrontation test. You know the confrontation test. But this confrontation test is very poor, because if you're doing the temporal side, you're sitting opposite your patient, and the target is on the temporal side here, and it doesn't disappear, because your temporal field goes all the way out to 90 degrees, 92 degrees actually. You can see behind you. So it's useless on the temporal side. The limit of the visual field is the face. So we can see 92 degrees this way, but above, our head, our brow is in the way, our nose is in the way on the nasal side, and our cheek here. That's the limit of the field. So outline perimetry is comparing the visual field to the outline of the face, so that you bring the target from the side, so you're sitting opposite, and the patient is looking just at you, 10 centimeters away, maybe 20 centimeters away, very close. And you just bring the target around the side and ask them when do they see it. But the target is almost touching the face, just a few centimeters from the face. And it's very accurate. It can be very good. You can pick up neurological defects in patients if you use this test. I've gone back to using it on every patient, every adult. It takes just a minute to do, in addition to central visual fields. And occasionally you'll pick up something in the periphery. Now, with a baby, if you ask them to tell you when they first see this coming round the corner, they're not going to tell you. What are they going to do? They're going to just look. So you say to the 2-year-old, look at my nose, concentrate here, look at my nose, look, watch, and tell me when the teddy bear comes, and they will look. Okay, you've just got to keep talking to them, look at my nose, and it works pretty well. So with one eye occluded, and with the child fixating the nose, the optometrist brings a small toy around the side of the head, working at a distance of 10 centimeters, and just compare the field. Now you can see what's happening there. Yeah? So the targets come around the side. Shall we turn that light off, please? Can you just switch that light there? Thank you. So the top picture there, you can see that the toy's coming around, and he looks there, and you can assess the field in that way. In fact, I videoed this one to show you last week. That's my magic wand there. Oh, well, I was hoping that would play, but it's not. Okay. It is a video. Ah, there we are. Okay. Now this girl is not a 3-year-old, but she has slightly poor concentration. Yeah, but she's telling me. Do you see? Yep. Yeah, there she did. Okay, all right. I think she enjoyed it. Okay. Right, okay. Now, are the eyes healthy? It's one of the main things when a child is coming in, we want to tick that box. The eyes are healthy. Tonometry. Can you do tonometry? Lights? Yeah. Let's put the lights back on, thank you. Can we do tonometry on children? Well, the Keeler pulsar is very good for that. And the other one, actually, is the eye care tonometer. Do you know the eye care?
Yeah.
You have it in hospitals particularly? We have one as well here. Yeah, that's great because it's a contact tonometer, but you don't need anesthetics. It's very easy to do. Okay, now with a pulsar, it's a puff of air. Here you've got to play games. You've got to ask the child to look at the red light, and you say to them, "What's your favourite cartoon character? Who do you like? Which cartoon?" I don't know what they watch nowadays. For me, it would be Popeye. Can you see Popeye in there? And they're looking. If you look carefully, you'll see Popeye. But if you close your eye, you won't see him. Puff. Oh, you blinked. Look again. And you get your readings. Okay. Slit lamp. Can you do slit lamp microscopy? Yes, you can. You can wrap them up in a blanket and put them onto the slit lamp if need be. Sometimes you have to look. When they're 2 or 3, sit them on a cushion or on the mother's lap. Now, my view is this. Whoever carries out an examination of a patient, whoever it is, child or adult, they should be responsible for making sure the eyes are healthy, which means looking at the retina. I think it's a very, very strange system in some countries in the world, like France, like Germany, and to some extent Israel. People come to the optometrist and they come to see if they need glasses, and they're going out blind. They're going blind. They haven't been checked, and they don't know that they've got to see an ophthalmologist for their regular health check. And there may be no symptoms. I mean, glaucoma is the case in point. Glaucoma, I think, is the 2nd cause of blindness in Israel, where in the UK it's the 5th cause of blindness. Now, if mydriasis is not used, then you can't expect to see a full examination of the retina. Now, often people put peripheral retina normal and they've looked with a direct ophthalmoscope. It's not true. You cannot see the peripheral retina. So dilation, of course, is important, tropicamide or sympathomimetics. Sympathomimetics are contraindicated in babies, particularly premature babies, we don't use phenylephrine. Phenylephrine 10%, which is available, should not be used anyway. It's too strong. 2.5% to dilate. But usually for a baby we'll use to dilate to look at the retina, we'll use cyclopentolate anyway, because we want to do a cycloplegic refraction. Of course, it's more difficult to examine a baby or a child, more difficult than an adult. Okay, so you can get the baby cradled by its mother. One little tip for you, and I don't know if any of you tried examining a baby who's asleep. Have you tried that? So if a baby comes in and they're in their buggy, they're in their pram, and they're asleep, and the mother says, "Shall I wake her up?" No. No, leave the baby as they are. You can lift the lids and you can do ophthalmoscopy, you can do retinoscopy.
If they're very asleep though,
The eyes go up.
all the way back.
They go all the way back. But you can get something, you know. It's sometimes more that way than if you wake them up. Okay. Babies and infants tend to fixate on the light, don't they? They fix on the ophthalmoscope light and you get nothing but the macula. But you want to see the optic nerve. And there's that Bell's phenomenon that you just talked about, Dina. Okay. So we've got the direct, you know about these systems. You all use a direct ophthalmoscope, I guess? Yeah? Okay. And then there's the binocular indirect. Now, this is the technique that I would advise the headset when you've got a baby, because at least you get some view of the periphery as well. But it's difficult, and you need to dilate, and you don't get much time with the baby. It's such a strong light. That's the problem there. Very bright light. Then there are monocular indirects as well, which are available, which are useful, like the Welsh Allen. Does anyone have a monocular indirect for looking at babies? No? Anyone have a headset? Okay. So you're going to rely on your direct ophthalmoscope.
Oh, you can use the plastic tube with a direct ophthalmoscope and do indirect.
You can. Thank you, Al. Yeah, that's absolutely true. If you don't have an indirect, you can use your direct ophthalmoscope and take a +20 lens, having dilated the patient. What is very useful is this is an old picture, but it's of an Optos wide field image, and interestingly you can get pictures on babies with this. Nothing needs to be in focus. You just put the baby near and everything's in focus. So you may not get a full field, but you'll get something. And there are smaller models now. I've not updated this photograph. So can digital imaging help us with babies and children? Yes. Regular fundus photographs. I think probably 70% of optometry practices in the UK now have regular fundus cameras.
How about smartphone?
Smartphone technology. Yeah.
I have it. I can use it on children, not 1 year old, but
And it works for you?
yeah.
Yeah. Dilated?
You can, no, not dilated.
Yep. Yes, there are a number of smartphone technologies now available, software. I've got no experience with them.
You can do a video and you can do just shots of pictures.
That's great. So IL will tell you which one you use.
I think it's called.
We've got Peak upstairs.
Peak, yeah.
Oh yeah, you have also here, yeah. Right. But this is different. I think mine is easier.
I saw Peak being developed for some years, and I didn't realise it was been released now.
I don't think it's released to the general public. We've just got one in the university.
Okay, yeah. I mean, it's great. It's a great idea because it can be used all around the world. It can go on any iPhone, basically. Okay, but regular digital imaging is used on young children quite routinely in the UK now. And pupils are very often large, so you don't always need to dilate for this. How about younger? Actually, looking at that is very nostalgic for me. The one on the left now, Boaz, he's 19. It's my one of my sons. And the little one on the right, Tally, she's 17. And that was when they were small. So how young? Well, here we've got an Optomap. This is an old image here. This is of I think this is maybe my little girl there. So she was 6 months, 9 months old, something like that. So you can get down young very easily. And if that's not young enough for you, this one here is a baby that's now 3 months old, that was born 3 months premature. This is not my image. This is an image from a paediatric ophthalmologist in the States. And you can see actually that they've used calipers here to hold the lids open. And you can see the hypoplastic optic nerve. It's a grey, poorly developed nerve. Okay, and actually this is, I think, was the first patient I ever did an Optomap on about 15 years ago. And I tell this story because this was a 5-year-old child who came into the practice complaining of symptoms. Mummy, I'm seeing spots in the clouds. So I looked with a direct ophthalmoscope. I dilated, I'm going back a few years, dilated, direct ophthalmoscope, indirect ophthalmoscope, headset, Volk. I couldn't see anything, couldn't pick anything up. It's a 5-year-old, it's difficult. And then I remembered yesterday we had our new Optomap imaging system delivered. We had no lessons on it at all. And so we did a picture. This actually is some years later, but nothing's changed. And you can see here there's a hole here in the retina with a localized retinal detachment and an operculum just there. The piece of retina's come out of the hole. And I thought, well, what am I going to do with this? This is a 5-year-old. So I spoke to the mother and said, look, there is a retinal tear. It's small. If he was an adult, I wouldn't do anything because they don't usually progress. I mean, in the UK, they're not usually treated. In the USA, they'll probably be lasered. So I rang. She wanted to see someone privately rather than through the healthcare system. So I telephoned a private retinal specialist and left a message for him. And I said, I've got a 5-year-old with a retinal tear, an operculated tear. Can you call me back? So his secretary gave him the message, and he called me the next day, and he said, Simon, I'm ringing you back about the 55-year-old with the operculated tear. I said, no, Tim, it's a 5-year-old. He said, it can't be. I said, it is. And he said, are you sure? I said, yeah. So I sent him the image, sent him the child. He didn't know what to do with it. This is an ophthalmologist who only does retina. Okay, so he sent the image up to a paediatric retinal specialist in Manchester. Okay, and they agreed to do nothing, and they asked me just to image the child. So for the next year, I imaged him every 3 months, and then it went to 6 months, and now it's annually. And I think I haven't seen him for 2 years now. Nothing's changed. So this technology is great for screening. And there is a saying which I'll come back to. It's not rare if it's in your chair. Okay. You often have conditions like ophthalmos, which are rare, but if you've got one sitting in front of you there, it's no longer rare. Okay. So expect the unexpected. It's difficult. If you're seeing presbyope, normal child, and then something very rare, you get caught out. And there it is there with a localized detachment. OCT. Now we've had OCT now for about 10 years. We're on our 3rd one now, number 3, okay. And by the way, the big multiple chains, like you have here, what are your big ones? Opticana, there's others as well I know here. Our equivalent, they've all got retinal cameras, all of them. And they've all got visual fields, because by law you've got to have visual fields in the UK. You can't practice without. But they're starting to put OCTs in their practice now, because actually you can't practice properly without an OCT. You can't diagnose macular problems properly without it. The problem which they haven't seen yet. When you put technology in, you've got to use it. And if you use it, you have to interpret it. And the interpretation can go wrong. And then it's all very well having the evidence there, but that evidence is there that you didn't analyze it properly. The problem was there before. So we see that increasingly. So we use OCT very often actually to look at swollen nerves, crowded discs. So have fun with the children. It is good fun. It's very exhausting, I find. I used to, at one time, for about 2 years, I think my practice was 95% pediatric. And then I decided I can't carry on with this, and actually changed, and it's a sort of better balance now. Okay, I think we'll have a 5-minute break. Are there any questions at all?